Good afternoon or good evening, everyone. Thanks for joining the CPRN webinar on how to partner with CPRN to conduct multi-center clinical research. Let's see if I can get my slides advancing. So my name is Paul Gross. I'll be your host. I'm the chairman and founder of the Cerebral Palsy Research Network and an adjunct associate professor at the University of Utah. And then we have two other speakers who will be joining us tonight, Jacob Kean from the University of Utah, Dr. Michael Kruer from the University of Arizona and Phoenix Children's Hospital. Okay, so I'm going to start with giving you a quick background about CPRN so you understand the context of what there is to partner with. CPRN was founded out of an NIH workshop on the state of science and treatment in CP that was in November 2014. At the end of that two-day meeting, the organizers organized task force to move forward the findings of the meeting, and there were 5 key areas that we decided to advance. Start a national registry for CP, pursue more comparative effectiveness research, increase the study of adults, grow the field of young clinician scientists, and advance basic and translational science for CP. I headed up a task force with Deb Gabler to look at a national registry and what grew out of that through partnership with Rich Stevenson and Diane Damiano, who were running the comparative effectiveness research question, was the founding of the Cerebral Palsy Research Network. And it was really founded to do 1 through 4 of those key tasks that we were pursuing. It was the merger of 2 large experience bases, one that I had from co-founding the Hydrocephalus Clinical Research Network in 2006 with Dr. John Kessel from the University of Utah, and then Dr. Gary Norritz, who is a developmental pediatrician at Nationwide Children's Hospital, and he had been running a single center registry called Learn from Every Patient. And I'll talk about what about those core experiences we borrowed from. And then given that I am the father of a 14-year-old boy with spastic diplegia, we started out being patient-centered from the very beginning of the founding of CPRN. So our mission is to improve the outcomes that people with cerebral palsy value most. So I'm going to underline that, through high-quality clinical research and quality initiatives. And I'll come to the part about how people value most a little later in the presentation. So what is it? What is CPRN? Well, it's basically a collaboration of institutions and of clinicians and therapists and clinical researchers and patient advocates that are very interested in conducting research and quality initiatives. Physically, it's a data coordinating center based out of the University of Utah's Population Health Sciences department. And it has 2 core assets from a software or data collection perspective: a clinical registry that characterizes patients, characterizes the interventions they receive, and captures both clinical and patient-reported outcomes. And it's captured through today Epic, the leading one of the leading electronic medical record systems, and then also potentially through REDCap. That is called the CPRN Clinical Registry. And then we also have a patient-reported outcomes registry that can follow both children and adults, and people can participate in that from anywhere in the community. They don't have to be part of a CPRN center to participate in the PROs that are available there. So this just gives you a sense of where we are physically, and then the key there will show you that the green sites are currently enrolling patients through their EMR or through REDCap. The yellow sites are working through the Epic issues to deploy and start collecting, and they shall be collecting imminently. The red dots are working through more of the compliance. They almost all have an IRB approval, but they're getting either a business associates agreement or working through the technical issues to get to the point that they're ready to deploy. And then I've got a couple blue dots on there, and those are actually candidate sites that have taken the steps to begin to join CPRN. And we're just as a matter of format, we're gonna, if you can hold your questions to the end, we'll open it up for questions at the end of this. So the status is we have 18 sites that have that IRB approval for the registry, and they have a data transfer agreement or a business associates agreement in place. 7 of those sites are actually collecting data, and as you saw, there are several more that are imminent. The community registry with our PROs is set to launch in March. So that will allow us to get PROs out to a very broad cross-section of the population through patient advocacy organizations. And then we have the Data Coordinating Center is fully funded to create and manage the registry and to manage the process of pursuing granting opportunities. We initially got funded by PCORI to conduct a patient-centered research initiative that we called Research CP, and the goal was for that to set the priorities, and that's why I referred to the outcomes that that people with cerebral palsy care about. Talk a little bit more about that in a moment. We have several study groups that are working to define concepts, and our standard operating procedures, which are available on the web, make it so that anybody can bring a study to CPRN and propose it and partner with us, and that's what tonight's presentation is about. So Research CP set our focus areas. There are 20 top priorities, or 16 top priorities that were listed out of that, though there are more in the appendix that are very important. The key areas that things grouped under were more comparative effectiveness research for interventions, more information or more research on exercise and physical activity and what's the impact on chronic disease risk, really understanding aging in the CP population, and then there were several other ideas that were sort of did not group with other ideas that were important as well. And that paper is actually publicly available from developmental medicine and child neurology. So this is our study pipeline. So our goal in this call is to invite you to help us get more bubbles in the front of the pipeline and to move them along. So if I work from the right-hand side, we have that one paper that we just described that is published. We have 2 more that are in the mill, one that's been submitted and one that is imminently going to be submitted. We are executing currently both a quality improvement protocol on intrathecal baclofen pumps and the CPRN registry. And then we have a number of studies that are in the development phase after having been approved by our investigator committee. So you're going to hear from Dr. Michael Kruer about his genetics study, which was funded by, pardon me, for some reason that slide's on a timing. That was funded by NINDS, and then we have an epilepsy study group that was funded by the Pediatric Epilepsy Research Foundation. And we have several other studies that are in various stages of development, like this study we recently approved the concept for, which is about spasticity management in the non-ambulatory population. And that is actually being driven by one of our young investigators. So it's part of that 4th point of growing the field. And then several other areas that we're working on, and we really want to flesh out the places where we have holes in the Research CP opportunity map. So what is unique about CPRN? Well, it connects to the EMR so that we avoid duplicate data entry. And that's a key factor. As the HCRN that I co-founded, we use a clinical research assistant at each site to collect data. And while that gets you good, high-quality data, it's very inefficient from an expense perspective. We're able to link these EMR-extracted records to the patient-reported outcomes, so we can have that clinically validated data to go along with patient-reported outcomes. And we enable the study of long-term outcomes. It's a longitudinal registry, both the community registry and the clinical registry. Jacob's going to talk a bit about some of our strengths in doing causal inference and how that's a a valuable skill that's part of our data center. And overall, what we're trying to build is a sustained platform, a continuous improvement platform for conducting research. And in addition to having patient-centered leadership and someone that sort of curates our community overall with Michelle Schusterman, we actively try to involve the patient community in the research studies from the defining phase onward. So there are really two paths to go down in partnering with CPRN. What we're talking about tonight is the left-hand side, which is how you can partner to accelerate a research concept and really get the benefit of a set of people that are already set up to conduct multi-center research and that are looking to collaborate. How you can strengthen your applications because we can provide preliminary data from our registry, and the fact that we already have a research infrastructure set up reviews very well in study sections, and we have the database and the statistical resources for the studies. So it basically simplifies research execution. I'm not going to talk about joining CPRN tonight. That is also an option. There's a lot of resources on our website about how to do that. Provides tremendous opportunity for both academic opportunity, mentorship, and just participating in the registry and research overall. The types of studies that we support or that we can partner around are, we're really set up to do multi-site clinical studies. And so that can either be initiated by a CPRN investigator or by partnership with an external investigator. We can do registry referral studies, and that's what Dr. Kruer is going to talk about tonight, where we can refer patients from our registry and use that to provide a lot of the phenotypic data or a lot of the richness that the registry provides. People can come to us with proposals to study our registry, so you can make a proposal for a registry analysis. We also are already running a multi-site quality improvement protocol and want to expand opportunities there. We've been talking to some of the folks about some of the care pathways at AACPDM as a mechanism to do that. And then the community registry provides a whole different avenue for study, and that's got a lighter weight approval mechanism where you can just be approved by our executive committee and have an IRB to start conducting a study that's a PRO against our community registry. So with that, I'd like to turn over control to Dr. Jacob Kean and have him talk to you about some of the resources and capabilities of our data center, data coordinating center. So let me give you remote control. All right, Jacob, I do believe you have control.
Thank you, Paul. I am advancing, but unlike during our test, I don't see the slides advancing. Here we are.
So you just advance. So spacebar will advance, or you can click down in the lower right-hand corner where there are little arrows.
Oh, I used the arrow keys. It appears that it worked. Or did you advance that?
No, you did that.
Okay, very good. All right, so now I have control. Thank you, Paul. Who we are a group, the Data Coordinating Center that is in the Department of Population Health Sciences. That includes 3 divisions, 2 of which are represented in the Data Coordinating Center activities, and those are Health Systems Innovation and Research and the Biostatistics division that includes the Study Design and Biostatistical Center. And so the set of collaborators are listed here, in addition to our team at the Office of Sponsored Projects at the Senior Vice President's Office. These are the folks that we work with directly on grants that we initiate or subcontract grants that we work with on as partners with our sites or external partners within CPRN. I'm advancing, Paul, but not having luck. Okay. Oh, Not having success. Everyone still there? Paul, can I hear you? Okay.
I can hear you, Jacob.
I can hear you.
Thank you. Sorry, I wasn't hearing anyone. I'll continue on. We serve sites in a number of different ways. First, for the site's own contributed data, sometimes we get requests for that data. The deliverable for us as a data coordinating center is to deliver back the raw site data. These are data that are not cleaned and not checked and not analyzed and queried at the level of site. And this is one of the advantages of the business associates agreement that we have in place that serves as governance for the network. A BAA empowers us to be an agent of the health system that we're partnered with, and so we can do things like send data back to them or do analysis in support of quality or other sorts of projects that a individual health system would take on.
So I was muted, Jacob, before, which is why you weren't hearing my instructions. If you're having trouble, I'll advance.
Yeah, I'm giving input but not seeing slides move, so.
Okay.
Next. Thank you. The process to obtain one's own site data is just to email me. The data is posted in a secure repository for site PI access. The timeline takes just a couple of weeks to do this, and the cost is supported by DCC infrastructure costs. Next slide. For studies of clinical and community registries, next. For the clinical registry, as Paul defined earlier, these are data that are collected in electronic health records and abstracted from electronic health records into REDCap. We have roughly 900 data fields that reflect the spectrum of care received by individuals with cerebral palsy. This is multidisciplinary, and it's granular information provided by providers during the routine provision of care. And so in many cases, this is just routine clinical documentation that's more granular and perhaps structured. Next slide. The community registry, as Paul mentioned earlier, is a registry that individuals can sign up for outside of any clinical setting. It facilitates connections with and engagement of persons with CP outside of those contacts with the healthcare system. So not only can it be accessed outside, the focus is on life outside of the healthcare system. It enables routine assessments of registry-engaged participants and families, and enables targeted recruitment and participation for research. Next slide. One of the really unique facets of CPRN is the ability to connect these clinical and community registries using a global unique identifier, and it allows the connection of data collected in clinical settings with data that are collected outside of clinical settings. For instance, evaluating the impact of peer-to-peer support strategies on healthcare utilization, that there may be peer-to-peer support going on in the community registry, in a community commons kind of space, and the evaluation of that could be done using healthcare utilization data collected in the clinical registry. It also allows the assessment of long-term outcomes beyond a typical 5-year grant period. And so this becomes a very powerful tool in order to follow a cohort of study participants beyond any particular study. Next slide. We also provide service to network sites in the form of aggregated data and descriptive statistics. Next. We support requests. These are generally the sorts of things that one includes in papers and presentations. These requests must follow an approvals process that's outlined in the CPRN governance that you can find on the website. The deliverable for the data coordinating center is analyzed, tabled, aggregate data. Next slide. The process, again, is triggered by an email to the Data Coordinating Center. And the structure of the request, we spell out a number of different things, which elements, which CPRN data element names, which composite elements. So, for instance, surgeries and anti-seizure meds would be composites, and defining the set of CPRN data elements, again, by the name. Some of our team have no expertise in healthcare, and so being very clear in the structure of the request that can be interpretable by someone who understands the data very well, but not the clinical area is key. Next slide. It's also important to define a time period for the request. As you can imagine, with the growth in CPRN, you have sites that have come on at different times. That affects the sample that's available and has some scientific implications. And so understanding what data were collected, where and when becomes very important. And as more sites come online with data collection, it's increasingly the case. Providing mock tables are also helpful. They add clarity and can be populated directly by our informaticians and statisticians with data. Next slide. Here's an example of a mock table that includes CPRN data elements and specific data element names and the breakdown about what's being requested. So it becomes clear to us exactly what is needed to be provided. Next slide. The timeline for this is 3 weeks or so. The cost really depends. If it's just aggregated descriptive data, is inexpensive, roughly $1,000. Next. The service to network sites includes also aggregating data and providing inferential statistical analyses. Next slide. The deliverables. First, this is a statistical analysis plan that we would develop in support of the sites or partners. We would provide analyzed, tabled, aggregated data, and an analysis section for a presentation or a paper that's co-developed with our team. Process is triggered like the others with an email to the DCC, where we would schedule a consultation. Just like with the descriptive statistics, these requests would follow a standard CPRN governance process. Next slide. A successful consultation for us includes things like clarifying the research questions and hypotheses, determining the study design, and discussing inclusion criteria, potential analysis, study limitations, and the whole process, research process from soup to nuts. Next slide. The statistical analysis plan that's developed at the Data Coordinating Center includes an introduction where we have our understanding of the study design and overview, includes the data that we expect to be included in the analysis, the research objectives, and then a detailed plan of the application of methods that will be used to accomplish the objectives. Having a statistical analysis plan helps to mitigate threats to the interpretation of the data, and it facilitates research reproducibility. And so we believe strongly in developing these and have had a lot of success in doing so and are happy to help partners do this as well. Next slide. The timeline for this, well, as we all know, the time that it takes to write a manuscript or a grant or develop a presentation varies significantly by the number and complexity of the analysis that are planned. So the cost varies. Roughly, we've figured this out in study of interactions between our informatics and statistical teams with other investigators that this is roughly an effort that's $5,000 per, and that may be per paper or per grant submission or something like that. Actually, I should say, let me be clear that usually our work in terms of grant submissions, we build in the costs, and so that would be built into the grant budget. It's really just for papers that we have these costs. Next slide. And service to sites and service to partners also includes service in support of grant submissions, as I just mentioned. The deliverables really vary depending on engagement. At a minimum, we provide a package of documents that your Office of Sponsored Projects would use to put together the grant application. This includes biosketches, facilities, letters of support, and these sorts of things. The process must follow an approvals process that's detailed in the governance, as I mentioned, on the CPRN website. The DCC must also be committed to serve the project because, as you all know, there are a lot of hours in putting these things together, not only on the part of our team, but on the part of the teams that support us. And so it's a significant investment on our part and on yours, of course. The process is triggered by an email to the Data Coordinating Center. Next slide. Timeline for this. If it's a small subcontract, 2 business weeks before your internal deadline is the amount of time that we need. A week and a half is going to get a hard no from our Office of Sponsored Projects just because there's back and forth that's required both internally and externally. And so we want to be sure that we can deliver for you, and so need to follow these timelines. For greater engagement, it's 3 business weeks before your internal deadline. And the involvement is negotiated months prior to your internal deadline so that we can have the things to you that you'll need to be successful. The cost is nothing for grants to which the DCC is committed. And so once we commit, we want to deliver, we want to follow these timelines, and we want to support partners and sites with all the information they need for the grant to be successful. Next slide. This is example text from a successful outreach from one of our partner sites. And these are the sorts of things that our Office of Sponsored Projects team and our Data Coordinating Center team appreciate. This is a very clearly worded, as you can see, example about the things that are needed, including the announcement number and title of the grant that we'll need in order to do the processing internally. And also something that's often missing is the name of the lead site PI if you're a partner. It's something that's important for us to understand who we're working with, and even if we at the Data Coordinating Center understand this, it's often the case that our colleagues in our Office of Sponsored Projects who support us may not know. And so putting all of this information together that can be accessed is very important for our team. Next slide. Questions? Or we can hold those.
Yeah,
to the end.
I think we should hold questions just to make sure we get through, and then we'll allocate the time at the end for questions. So if people don't mind.
Thank you all.
Michael, you're up.
All right. So I think I'll take it from here. So I'm really wanting to just briefly describe what Paul had referred to as a registry referral study. So this is an example of a recently funded project through the NIH that we're calling DECrypt CP. Next slide, please. And so this, as you quickly realize, this project was something a little bit outside the scope or the original scope of the CPRN. We really, my research here in Phoenix, my research laboratory are focused on this idea that genetic mutations actually lead to CP in a fair proportion of individuals. And there's some data that suggests that this may be comparable to the contribution of things like perinatal asphyxia. However, this idea that genetics might contribute to CP is still something that's relatively new. Next slide, please. So I guess I do have some embedded pieces, Paul.
Okay.
This is just a pie chart showing some current concepts of different contributions to CP. Next slide, please. So the fundamental study idea, and we knew that families affected by CP are highly motivated, but in order to really get at the genetic underpinnings of CP, we needed to be able to study both parents and a child with cerebral palsy. We needed robust clinical information, and we needed to be able to collect samples from all three members of that core family unit. And we're able to do this by collecting saliva samples. This in turn allows us to compare the DNA code through whole exome or whole genome sequencing and find out what's different about the child with CP in their DNA code compared to that of his or her parents. So fundamentally, in order to do this kind of work, we needed to be able to partner with families, we needed to be able to partner with clinicians, and we needed to also connect with other researchers in order to pull this off. Next slide, please. However, in putting this project together, it quickly became evident to us we were looking for 500 trios, so 1,500 individuals, 500 families. This is more than could likely be recruited by a single center. Here at Phoenix Children's, we have a pretty robust CP population, but we quickly realized that we're really needing partnership in order to bring this to fruition. As I briefly touched upon, really having rich clinical data is really essential to try to understand how genetics might contribute to CP. If we do identify a genetic mutation, that information is only as valuable as the clinical data that we have to go with it. So knowing how the genes actually lead to symptoms is crucial. And in parallel to these genetic studies that we've been conducting, I had already become involved with Paul and Jacob in the CPRN clinically, recognizing that the CPRN, through its efforts, was really spearheading the collection of extensive longitudinal phenotype data. Next slide, please. So really, as Jacob just touched upon, the strength of the Data Coordinating Center was something that seemed a natural partnership ready to happen. Phoenix Children's was already a CPRN site, but as was mentioned, that's not necessarily a prerequisite. And we quickly realized that partnering with the CPRN would give us access to many, many more patients and families than we could enroll in just our single institution alone, as well as the opportunity to work with some great people, including thought leaders in CP. Next slide. So, I think in multiple slides, Jacob had outlined all of the different protocols and kind of SOPs that have been set up in order to access the CPRN and interact with the Data Coordinating Center. But I think you can probably appreciate that a lot of those fundamentally started with an email. And so that's the way that this project also started. I emailed Paul, really began a chat with the scientific committee that ensued. And as I mentioned, the CPRN, its focus was not necessarily on genetic studies. Sorry, I'm having computer issues. Okay. However, I think that all of us saw an exciting opportunity and that ultimately led to a presentation to the investigators community in mid-2017. Next slide, please. So at that time, we presented this concept. We're calling DECrypt CP. The name came later, but the idea was that we wanted to focus on, at least for the initial study, the kids that had CP but didn't have a clear reason why. Reasoning that that group of individuals would be highly enriched for genetic causes of CP. And so that led to ultimately an NIH R01 grant application, although I should point out that we're now planning a second R01 application, a follow-up, focused on all CP patients to try to better understand genetic contributions to all forms of CP. Next slide. So again, our pie chart. But as far as the design goes, fundamentally, we saw this as something that could be done as a spin-off from the participants' CPRN visits. So the study could be presented to potential participants during the course of routine clinical contact. The current approach involves providing an email that can be used to electronically enroll participants, and then to try to be as child-friendly as possible and to make it as easy for families to participate as we can. The study for several years now has actually, in earlier iterations, used saliva as a source of DNA rather than blood. And most kids much prefer that collection method. And 12-year-old boys think that spitting into a tube is a great way to participate in research. So the participants can mail back the saliva samples through self-addressed stamped envelopes with return postage. Next slide. And from there, we're able to extract DNA and conduct next-generation sequencing studies. So that's what we use as our launching off point to develop our extensive genomic data, and we're able to couple that with the clinical data, as I mentioned, that the CPRN houses within its data warehouse. So for this project in particular, we were fortunate to have seed funding provided for Cure CP in the early stages. And as I mentioned, we were targeting an NIH R01. That ended up being submitted shortly after that discussion with the CPRN. That fall, we got the reviews back. We were not funded on the first iteration, and surprisingly to me, even though we were proposing a very large-scale grant with both strong clinical component as well as basic science studies that you see alluded to on the right, the study section actually wanted more. We responded to those reviews and resubmitted the grant earlier in, last year, 2018. We were fortunate enough to score in the 10th percentile, and this project was ultimately funded in September 2018 by the NINDS. Next slide. So at this point in time, we're really excited about this opportunity to participate not only directly in the core CPRN initiatives, but also to participate and to really partner with the CPRN in this registry referral study. This has in turn led to additional opportunities, some of which are going to be discussed at the upcoming triannual meeting of the American, the Australasian, and the European Academies of Cerebral Palsy and Developmental Medicine. And this effort, in turn, is part of an even larger effort in cerebral palsy genomics represented by the International CP Genomics Consortium. So this is going to be discussed with a pre-conference meeting at that triannual meeting coming up in September of this year. Next slide. So in terms of future directions, we think that having now the capacity to collect samples in parallel with what's being done within the core CPRN effort actually is beginning to lead us in exciting directions. These are things that we hope to bring to fruition in the future, but I personally would love to ultimately see the formation of a CPRN biorepository that could be used for studies of DNA, RNA, proteomics, as well as other basic and translational science approaches. There's a wealth of specimens that are collected or could be collected during the course of routine clinical care, going from something as simple as saliva to much more difficult to access tissue, but something that nevertheless it would be possible in the CP population and could be quite revealing. Things like muscle tissue or cerebral spinal fluid, particularly for kids with intrathecal baclofen pumps. So I'm excited about the future and the possible integration at some point of neuroimaging data with all of the longitudinal phenotypes and biospecimens. But this is where we look forward to bringing things in the future. Next slide. So ultimately, in a nutshell, I would say that from our experiences, I can definitely say that the CPRN really does provide a very powerful platform for collaborative research in CP. Just in the process of submitting the grant, Jacob and Paul and the CPRN were outstanding collaborators and made the process as easy as they possibly could. Again, there's both data collection and analytical tools through the Data Coordinating Center that are available to projects. And finally, I just wanted to again highlight that the CPRN right now is able to provide access to extensive clinical data, but we hope that soon in the future it's going to be able to provide access to biological specimens to go with that data as well.
Great. Well, thank you very much, Michael. That was a very good example of how we can partner. Let me take people through a little bit about our data collection, our registries, and then we'll open it up for Q&A. So Jacob talked a bit about the types. We collect data from multidiscipline clinics. So we have things like the orthopedic exam. We have pre and post-op clinic visits for neurosurgery. We have high-level GDI data from the Gate Lab and some summary data on radiographs. We're collecting very detailed intervention data in orthopedics and neurosurgery. And we are just currently at this stage focused on lower extremity orthopedic interventions. So that is one limitation of the data that we're collecting so far. And then we are working towards collecting patient-reported sort of therapy and device history. We don't have that function rolled out yet. The clinical registry can play several different roles in research. It can be used for cohort planning based on queries we can do. It can. I know I've seen in HCRN how this was used to predict accrual to an incredibly accurate degree and timeline. It can be used for hypothesis generation, for looking at practice variation, and for these retrospective research of analyzing the longitudinal data that we're building in the registry. And then it can also be used as a complement to a study. It does not have all the fields or necessarily the quality in a given data point that you may need for a study. So it can be used in complement to a set of case report forms that get developed for a specific study question. So we have these data collection mechanisms. We have webinars that can show you a lot about this, but just to give you a quick sense, we have about 23 forms that have been built into EPIC. Actually, the forms have been built with EPIC and are available. The database, the CPRN registry, is actually built physically into EPIC that stores these data elements. So these are just examples from our non-surgical exam. We have REDCap analogs for all of these. This is just a screenshot of a PDF, but of course this runs in REDCap, and so we have several sites that use a clinical research assistant to do chart abstraction and fills in data through REDCap. And then we have My Cerebral Palsy, which is our consumer-facing web portal, which basically allows us to both engage the patient community in a dialogue about research, but also allows them to participate in the community registry. So they come in, they do a consent, and then they're presented with studies that make sense based on the basic information that we requested for them. Are they a caregiver? Are they a person with CP? You know, are they an adult? Are they a caregiver of a child? And then we can generate the REDCap-based survey questions that can go out to them for pros. We're also implementing some computer adaptive tests that we'll be able to offer as well. So if you want more information about resources, like I showed a map of the network, you can go to the website and you can see who all the potential partners are for existing sites. You can look at the study groups that we have up and running. And then in the Learn More section, you can look at our registry elements and download those. You can grab our standard operating procedures. We have our forms that in REDCap up there. We actually have our IRB protocol for the registry there and our strategic plan. So there's great resources. So before I open up to questions, I want to give you like the ultimate opportunity that we can offer in the short term is our standard operating procedures provide a way that you present a study concept. It's a 2-page concept that you say, hey, are you interested in this? And what's required is that it fits on the research CP opportunity map. You can sort of explain in the sort of background importance how it fits in with what consumers want as detailed in that. And then you review the concept with a CPRN investigator. If you have a concept that you think would fit, and we can set you up to do a review anytime in the next 8 to 12 weeks, if you are one of the top-rated ones that comes through that process, we'll invite you to join our CPRN investigator meeting that's in Ann Arbor on May 2nd and 3rd. So this will be 30 to 40 CPRN investigators. They come from all disciplines. We also have a couple people from the community that come and present a bit about their life story and how it relates to our different research topics. And then we go into a series of both full group and breakout discussions to move studies forward. So, our goal is to fill that pipeline. So if you have a study idea that you think would fit, we would welcome the opportunity to have you present that idea and start going down the path of collaborating with CPRN or just checking out if it feels like a good fit. So with that, let me open it up to questions. I muted a few of you because of background noise. I'll unmute you. If I'm sure we'll potentially accidentally stomp on one another, but if you have a question, just start to speak or back off for somebody else, and we'll see if we can answer your question. Or maybe your dinner is getting cold and you'd like to go and get that, which I totally understand as well. Margaret Wallen, did you ever get the ability to hear and see? I see it looks like you can actually speak.
Yes, I joined by the phone. I enjoyed the presentations and very powerful indication of the work that you've been done. Congratulations.
Okay. Thank you. I appreciate that. I was just checking to make sure you were able to get to see and to hear, so that's great.
Yeah, I'm grateful for that. Thank you.
Yeah. Okay, any questions for any of us?
Paul, it's Ros Boyd here. Can you hear me?
Yes, I can. Hi, Ros.
Oh, great. Good. Great system. Fantastic presentation. Really glad to see you're collaborating with Michael on his very important project. Have you sort of had any options for collecting and data banking all your neuroimaging data, or is that sort of a new future project?
That would be a new future project. I would really love to do that. We do that in the adult HCRN network. We set up an infrastructure to do that. It has some degree of cost with it, although storage is cheap at this stage. The software is cheap. It's really kind of the labor to get it there. So we have one of our neurosurgeons is a neuroimaging expert and is considering making a proposal and pursuing a grant opportunity. As you notice, Michael Kruer mentioned, biospecimens and banking in general. One of the things we're looking at is, can we come up with a kind of a program project grant opportunity where we could solve multiple research questions and have multiple cores, his genetics core capability and our imaging core, the registry, to pursue a set of things. And so that is an idea that's bubbling around, but we don't have a distinct plan at this stage. Michael, I don't know if you wanted to add to that. I know you've had some discussions with the folks at St. Louis as an example.
Yeah, no, I think you covered it pretty well, Paul. I mean, I think at this point in time, it's something that there's quite a bit of interest in. We would need a couple things to crystallize, and there's definitely interest from different groups, but nothing firm as of yet.
I know you've got some good data in some of your provinces in Australia. In fact, I've actually reached out to Iona to know whether or not a study idea that I have could access your neuroimaging. So definitely think it's an important problem to solve.
Yeah, no, I think there's a lot of discussion here, and like harmonization of data and having all the right sequences. So it's probably a good, and I don't know how much Michael's discussed that with the genomics group, but I think it's really good because just with all your structural imaging, if they have the 3D volumes and things like that, you can then harmonize the data and do very large data sets, which is what our CSIRO is doing. So happy to sort of put forward people to have that conversation if you're thinking about how you can sort of really build big data sets that can be harmonized.
Yeah. Well, we'll certainly keep you in mind for those discussions as we need like two more Michaels in different areas in the mix, and we'll be off and running. So, Michael, move on to the cloning phase, and we're ready to go.
And Roz, I plan to reach out to you at some point in regard to this offline. So.
Oh, great, Michael. Yeah, look, I know you've had Michael Fay involved, and I think it's just really because even just for the clinical scans could be harmonised, and with some of the work that Alex Pagnozzi and others have done, we could combine a lot of the data with minimum sort of, and be able to, but as long as we get the right sequences. And they've been doing a lot of this in Alzheimer's and adult stroke and stuff, and very successfully across multiple sites, multiple scanners. So I think they've kind of solved a lot of the issues, which would be helpful for you to know. Yep.
Yeah. I also want to do this with the Gate Lab, the motion analysis data as well, and get it harmonized. And I just think there's a bunch of machine learning that could happen if we can get some of these bigger data sets together in partnership with the clinical, just the core clinical data. So absolutely important ideas.
Definitely.
Yeah.
Yep. Good idea.
Anybody else have any questions about the presentation? All righty. Well, happy Friday to those of you from Australia who joined us, and everyone else, thank you for joining us. We greatly appreciate it.
Thanks,
Don't
guys.
hesitate to reach out. Okay. Bye-bye.
Right.
Thank you.
Thanks so much.
Thank you.
Bye-bye.
Thank you.